Hi, and welcome to We Speak Cancer. This podcast series was designed to just, help patients sort of navigate issues related to a cancer diagnosis. So, refocus on patient journeys as well as cancer prevention and cancer screenings. So today I'm really excited. We have Michelle Zimmerman, who is the founder of Previvor Edge, which is there are screenings I never knew that, honestly, as a cancer patient, I could have been doing, and I didn't because I did all my standard. But for certain groups who are at risk of cancer, the standard screenings aren't going to be enough. So I am really excited to have Michelle here to talk about, of course, Previvor Edge, as well as her own story and what motivated her or inspired her to start this company.
Yeah, Paula, thank you so much for having me. It's great to have the opportunity to talk all things prevention and personalized prevention when it comes to cancer, because there's so much more we could be doing. In terms of background and context, Previvor Edge was born out of sort of the intersection of both professional experience and personal mission. On the professional side, I've been in sort of the healthcare innovation space for 15 years, but it was running and scaling a cancer genetics testing company that really showed me some of our gaps, not just on treating affected cancer patients and precision medicine and the whole innovations there, which I trust there are many episodes on, but also the gap in identifying and differentiating risk and matching patients to the right intervention, screening and prevention interventions before they have a cancer diagnosis, and how much more we could do. So I sort of saw this firsthand, being in the field, being with doctors, being with patients, trying to provide better information to personalize cancer prevention. And then on the personal side, whoa, I got a tough family history when it comes to cancer. It's probably the best way to say that. I've got many, 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 many uncles, aunts, great uncles and aunts, parents, cousins with a variety of different cancers, mostly gastric cancer, pancreatic cancer, esophageal cancer. Unlike you, less on the breast ovarian side, but more on that side. And my mother's a physician. So from a very early age, I was told that I should get my colonoscopy early because we have polyps in my family. And I should just make one other point on this before we move on, to some more substantive topics. But, I got my colonoscopy early. Thank goodness they found, maybe one or two things. I do it every 5 years. My sibling also got it early when she was 40, and they found many, many, many polyps, and she gets it every year. And had she not had that colonoscopy, there's a pretty high chance she would have been diagnosed with colorectal cancer. So just having that information about my family history, sort of having the extra push to go do that, really was life-saving.
When I look at my own family, and we also had to have colonoscopies really early. My 37-year-old sister at the time saw blood in the stool, and her physician at the time wisely said, go get your colonoscopy. And the polyp was a precancerous polyp. And all of us, and we're very close in age, wound up having colonoscopies early. A couple of my sisters also had polyps. I did not, but it is really important to jump on those family situations just to stay ahead of the curve. So that was something that jumped at and took care of very early. And my sister Julia, who was the one who had the polyp, you know, she has colonoscopies now every 5 years for sure.
Yeah. I mean, I'll just like make sort of one other point, just like on the breast cancer side of the house, that family history and that pattern is so important. And now
Yes.
with breast density and ways to calculate your lifetime risk and really, really good screening. I mean, if we're, I know we're going to be talking about other types of cancer, but if we think about breast cancer and colorectal cancer, like these are cancers where we have really, really good detection methodologies, and we even have guidelines for how we will change how often we look for cancer, when we start looking for cancer,
Right.
what type of diagnostic or screening we use to go hunting for cancer. And I think one of the biggest gaps that people don't know, they do not know that they could be hunting differently and earlier and with different types of screening because they're not having the conversation about their cancer risk.
Yeah, that's right on. As someone who was diagnosed with ovarian cancer in 2024, I can tell you, I always thought of myself as this poster child for having my cancer screenings on time, mammograms, I would go and see and have my pap smears done, everything except what I probably should have been looking for. But there is and are no screenings directly for ovarian in the standard, testing arena. So, what can someone do who maybe, pancreatic cancer, for example? They may or may not have a family history of it. May have a family history of other cancers. What would you recommend for someone to sort of like have a discussion with their doctor about that involves maybe taking a closer look?
Yeah, I think it's like a great question. I think there are some major pillars of investigation if you really want to get a handle on your cancer. One is your family history, as you noted, just
Mhm.
patterns of family history. I have one or two relatives with pancreatic cancer. I have one or two relatives with ovarian cancer. I have one or two relatives with colorectal, with melanoma, with lymphoma, with like the list goes on because we do not know so much about cancer. And cancer is not one thing, it is hundreds of things. But our knowledge is getting better and better and better. And so, at Previvor Edge, our clinicians are seeing patients every day who, for example, have a family history of pancreatic cancer. We do have guidelines, some of which say, once you reach the age of 50, if you have a couple of first degree relatives, you can get an abdominal MRI to go looking for pancreatic cancer, which is not standard screening. We never go looking for pancreatic cancer in standard
No,
screening. And there are even clinical trials, one in particular called the PROCEED trial, that people can access the screening for free. And so they don't have to worry about insurance coverage by enrolling in the trial. I think, the other piece, like let's take ovarian cancer. We see patients with a family history of ovarian cancer. Well, as you mentioned, there's no effective screening for ovarian cancer. And frankly, having a family history alone doesn't qualify you for any screening if there was screening. And so what can we do about it? Well, one of the things that we always do is we counsel on symptoms. That's like one thing that's important because, if you think about cardiology as an analog, somebody who has an elevated risk of having a heart attack or a stroke, the cardiologist does a few things. One is they do everything they can so that you don't have a heart attack and stroke. The other thing they do is they educate you on the symptoms of a heart attack and stroke. So if you have those symptoms, you don't ignore them and you go to the hospital and you look at the symptoms a little bit differently. And so even symptom education sort of could be valuable. And then sort of the last piece, which I know we're going to get to later, is sort of some of these emerging screenings that are imperfect. They're definitely imperfect, but they could be better than nothing. And we have these conversations every day with people because there's cancers where we have standard screening, where people with a different risk get those screenings earlier, more frequently, etc.
right, right.
Then we have cancers where we don't have standard screening, but screening exists. Like it could be your low dose lung CT. Not everybody gets it, but if you meet the criteria, we can screen you for lung cancer or pancreatic cancer or an endoscopy. Like there's other things. And then there's cancers where there's no screening. There's no way to screen someone for leukemia or lymphoma. And I
Right.
think that's where the hope is of some of these multi-cancer detection tests who can at least tell you something more than nothing.
I learned a lot after the fact. When I look at my family, all I know, my family history, I had a grandmother who was diagnosed and died from pancreatic cancer. And I have a great aunt who had breast cancer in her later years. And that was it. Now, does it mean that other family members didn't have cancer and just didn't, sort of talk about it? Well, that's a possibility. I do know that I was presenting symptoms to my physician, my primary physician, fatigue, maybe a little lack of appetite. But it wasn't until, I really presented symptoms that, you know, uh, it was dealt with, and I had a CT scan of the abdomen, and I was diagnosed. But there is a blood test. You've probably heard of it, the CA-125, right? It is so simple that even though I had no family history of ovarian, every 6 months I would go back to my primary care physician and say, "Oh my God," and she must have thought I was nuts. I was like, "Oh my God, I'm exhausted all the time. What's going on with me?" And I try not to think about it too much, but that CA-125 shouldn't be that expensive to run, and just to sort of rule out, and I know it's not necessarily a reliable screening by any stretch of the imagination, but it is something.
Yeah, I could not agree with you more. I mean, the other thing that's interesting, just on the topic of symptoms, which is something I've learned from the clinicians and from our advisory board, is if you have a symptom that is like persistent,
Right.
and it's bothering you, you just take it seriously. And so we actually have, if we get to cover it on sort of what are all the things that inform your cancer risk, one of the things is, do you have any active symptoms? And it's not a symptom that you have for a day and went away. It's symptoms that are active, that are persistent, that have been
Consistent.
around. And so we make sure that if a patient comes and they have a symptom and it's not being managed or looked at or investigated by their primary care doctor or their GYN or their urologist, that we are making sure that they have a path to investigate it, because that is indicative that something could be wrong and we don't want to miss anything. So we take it
Right.
very seriously, because that's our angle, obviously. We're not coming from, everything that could possibly be going on in your life. We're sort of saying, do you have something that's different or multiple things that are different? Is it going on for a long time? Have you figured out the source? No. Okay, well, what's the plan? If you don't have a plan, we're here to make a plan with you so we can get to that source.
So I think that's a great segue. I'm just so impressed with sort of the patient focus element of Previvor. If you could maybe share your screen and just take them through like the assessment and then all the great info. And in addition to just the screening part of it, the cancer prevention part of it is also really fascinating to me, because we've talked about health and wellness on this podcast before, and I love the fact that it's integrated into what you're doing.
Yeah, perfect. And just, for context, Previvor Edge is really designed to help people understand their personal risk of developing cancer. So they have every opportunity possible, like Paul and I were discussing, to screen differently if they have an elevated risk, to be more educated on symptoms for cancers that they should be more aware of, to take every opportunity to engage in prevention, whether it's lifestyle or vaccinations or certain vitamins like vitamin D, and to feel a bit more in control of a process that's very out of your control. There's lots of parts about cancer we still don't know, but we know 40% is attributed to lifestyle and prevention
Right.
activity. Like that is known. We know
That's a huge
10%.
amount.
Right, 10% is attributed to obesity. And for some cancers like endometrial, that's 50% of endometrial cancer is attributed by obesity. And a recent study just came out. It is sort of more of a retrospective study. They looked at 150 million patients through a data set from Trinetics. And I think they found that irrespective of age, irrespective of BMI, a GLP-1 can reduce your colorectal cancer risk by up to 26%.
Wow.
Crazy. It's crazy.
Wow.
So there's a lot. I think the thing that we were going to talk about, and I'm just going to pull it up, you're looking at a part of a care plan of a patient who goes through the Previvor Edge program. And specifically, we're looking at risk factors. And we thought it was important to talk about this just to give the audience a view of all the different things you want to take into consideration to better understand your risk of developing certain cancers. So age matters, obviously. 80% of cancers are happening after the age of 40, and the average age of diagnosis is in the 50s. Your ethnicity also matters and your background matters. So different groups of people have different patterns of cancer, whether it's Ashkenazi Jewish people and the BRCA mutation, or Asian women, sort of in lung cancer. And so like you do see these patterns and you don't want to ignore the patterns. You just want to be aware of them. Medical history. Do you have reflux? Chronic reflux can increase your risk of esophageal cancer. You want to understand that. Do you have Crohn's disease? Crohn's disease can increase your risk of colorectal cancer. You want to know those kinds of things. Your BMI, of course, we talked about obesity, and it's really less about BMI and more about your fat percentage that you really want to be managing. We talked about active symptoms and whether they've been managed. Prior screening. I think a lot of people don't realize that if you have a finding on a past screening, that actually can increase your risk. It's not just specific to that screening. So finding polyps under colonoscopy informs the frequency of when you have your next colonoscopy. Is it every 5 years, every 10 years, every year? Your skin type. So we know more people are prone to melanoma just based off of skin type. Risk increasing infections, whether it's H. pylori or HPV or hepatitis B, these can increase your risk of liver cancers, cervical cancer. Vaccinations, so HPV vaccines and hepatitis B are protective. Medications, whether it's an immunosuppressant or whether it's certain types of HRTs, can sort of affect sort of your breast cancer risk. So you just want to be taking the right one. We look at your labs, of course. As I mentioned, vitamin D can be protective. You want to do a 3-generation family history because you want to see the patterns. If you're a woman, you want to understand your lifetime risk of developing breast cancer because there's different screening options. For some people, and we could talk about genetic testing and talk about who should get it and who might not be eligible but might still benefit. Lifestyle. So while there's a lot of lifestyle factors that could help you reduce your risk, like exercise and sunscreen and fruits and vegetables, there are lifestyle things that increase your risk, like alcohol and smoking. And so we should think about lifestyle as both helping reduce your risk overall, but also specifically alcohol and tobacco is frankly increasing your risk for many different types of cancer. And then environmental factors. We can't ignore, people who've had long-term exposure to asbestos or benzene. And again, while we may not have perfect screening, just knowing the relationship between these exposures can help people be more aware. And as we get better screening, take advantage of that.
That's considering everything. Wonderful.
One of the things we grappled with, and we were asked this many times, is why don't you focus on one cancer? Focus on breast cancer, or focus on colorectal cancer, or focus on lung cancer. And we said, well, wait a minute, if you're a patient and you sort of like you walk through the front door, like you just don't want cancer or you want to catch it early. And if you're going to spend all the time talking about family history, you want to engage in all the complexity of it. And that there's a lot of overlap in lifestyle and your underlying health and your age. And so we took the position of, can we create a process to be able to take all the variability and still help give someone an answer that's personalized to them?
I like that you actually include environmental factors, because that is something that, I think I'm hearing more and more in research and actually from clinicians about the impact that the environment has, of course, on the body. And I think if you look back historically at the increase of cancer, it happens, once we hit that industrial age. So it's there for sure. You know what? You showed and you shared what people could do to fill out information just so that they can maybe schedule an appointment or get assessed in terms of risk and or screenings that maybe they should be looking at. So I was wondering if you could share that.
Yeah, absolutely. So if you are currently in New York, New Jersey, and Connecticut, you can just put in your name. And so you can just do that. And you can choose to use your insurance. So we're in network with Aetna, Cigna, United, and Blue Cross Blue Shield. Or you can just pay cash pay. I'm just going to choose cash pay so that I don't have to put in all my insurance. And then you just pick your time. So maybe I want to do it out in July. And you're scheduled. And so, you're going to be meeting with Carrie. And as I was mentioning to you before, before somebody comes to see us, we ask them to fill out our Previvor Health Assessment, which is built specifically for understanding and managing cancer risk. And so we ask some things about you. We want to know who your care team is because we want to be collaborating with you and them. We ask you about your health history. We ask you about your lifestyle and environment. And of course, we go very, very deep into your family history. And all of this information is available to the clinicians before you come see us so that we can have a really, really robust conversation. And this sort of if we've learned anything from the patients who've gone through the program, is everybody sort of has something, especially if
Yeah.
you have a family history of cancer. Over 90% of people sort of learned that they had some sort of different risk level that they could manage differently that they didn't know about.
So let me ask you, say, what would you consider a family at risk for cancer? Is it one relative who's had cancer? Two? Do you quantify that?
So the answer is we do quantify that. And if my colleagues, my clinical colleagues were on the phone, including our cancer genetic counselor, there's like a lot of nuance. There's things that we know, like obviously colorectal cancer is very easy. If you have a first degree relative diagnosed before the age of 50, your risk is double. Like we know that. We know that if you have, one first or second degree relative of pancreatic cancer, ovarian cancer, you have some sort of elevated risk. We don't know how much more. And so I'm not trying to skirt the question, but it's kind of complicated. Like if you
Yeah.
have, and we've seen patients who have three family members who've had leukemia, some of them really young. And, we have this patient and it's like, well, what does this mean for my risk of leukemia? And sort of the pattern of this leukemia in your family is very odd for a cancer that isn't as prevalent. But exactly what this person's risk is, we can't quantify because we don't have enough data. But
Yeah.
we know enough to say, hey, there's a suspicious pattern. We should be more vigilant about this. We should be making sure you have a CBC differential and you're talking to your doctor. And so everywhere that there is a guideline or there is evidence, we incorporate it. Whenever there's a specific number of how it changes your risk, where there's published evidence, we use it. And wherever we know there's something, but we don't know exactly what it is, we describe it.
So just because I'm only versed in the standard screenings, could you talk about some of the screenings that people may not know about that maybe you've actually had already, and that is it something that you can simply talk to your physician about, or how could someone go about having one of these screenings? Like I've talked to people who have had the full body PET scans, but I know there are others that are out there.
Yeah, I think great question. I want to break apart the question into sort of like
Sure.
two pieces. Sort of what exists in evidence-based standard of care screening based off of risk? Like what do the guidelines tell us? And then what new diagnostics like a full body MRI or a blood-based screening test exist that frankly, I would say anybody, because like some of them are indicated for people over 50 but like basically you could go buy it online. It's very easy to access. Just on the first bucket, we talked about colorectal cancer, which is really colonoscopies and frequency, et cetera. That's a gold standard. We
Right.
talked a bit about breast cancer, which is sort of nailed the guideline is a mammogram every 1 to 2 years. But with so many women with breast density, it's, usually a mammogram coupled with an ultrasound because a mammogram isn't very good as a diagnostic or as a screening tool because the breast density gets in the way. And then you have people who have a more elevated risk. So maybe their lifetime risk is above 20%. And there they might get a mammogram with contrast or an alternating MRI with a mammogram. And they might get two hands-on breast exams a year. And so it's just about more frequent screening with more sensitive modalities. And then there's obviously, we talk about lung cancer, which is your low dose lung CT, but that's linked to, frankly, pack-a-day smoking, where the majority of
Yeah.
people who are diagnosed with lung cancer do not qualify. And so we have a real gap in lung cancer on screening. And then obviously you have your pap smear, which again is sort of how frequently you get it and which type you get it and whether you get a HPV blood test sort of depends on your risk level. And then there's screening that it sort of doesn't fall into that, like an endoscopy, if you're at risk of esophageal cancer, or abdominal MRI, if you're at risk of pancreatic cancer. Or we talked about the CA-125 and the transvaginal ultrasound and the combination for ovarian cancer, which is
Right.
debatable. People do
Right.
it, but the effectiveness isn't there. And then there's people who have significant genetic mutations and are getting a full body MRI covered by insurance called Li-Fraumeni syndrome. Those are people with a genetic mutation that increase their risk of so many different types of cancer that they actually get a full body MRI under insurance. And so there's sort of like a whole menu of ways to screen there. But even with that, there's things we can't screen for. Like we said, we're not great at blood cancers. We're not great at ovarian cancer. But outside of what the guidelines tell you, there's sort of a few different major innovations in the marketplace to help us understand our risk better and get screened better. So one obviously is the full body MRI, where there are no clinical guidelines. There is no evidence about the value of a full body MRI, but it exists. And there are definitely people who have found things that have been actionable and beneficial. And there are definitely people who have found things that sent them on a wild goose chase and caused a lot of stress. And so it exists, they're available, but whether you should get one and how often is sort of going to
Yeah.
be dependent
Yeah.
on a combination of like, why are you getting it? What are you worried about? What do you think you're going to learn? Right. And obviously, how much you want to pay. So it's sort of like a combination of those things.
Right.
And are
Right.
you the kind of person who's going to be worried about something and it's going to create more anxiety, or you're the kind of person who's going to get peace of mind? And so it's really buyer's choice, I think.
Yeah.
And if we contrast that to multi-cancer early detection tests, which is blood-based screening specifically for cancer, whereas a full body MRI is going to look for things other than cancer because it's just looking at your body and it's
Yes.
going to help you assess all kinds of things. With GRAIL and the Gallery test, they've done very large prospective trials with tens of thousands of patients. The data is imperfect, but I think the latest study maybe found, and don't quote me on this, it's like 60% of the time when they say you have cancer, you're right, they're right. 40% of the time they're wrong. And then there's always a question of what stage cancer are you catching it as? Are you catching it at stage 1? Are you catching it at stage 3? And then there's a lot of variability of the effectiveness because it's looking for every single kind of cancer. And each cancer sheds differently. I'm sure there could be like 5 podcasts on this, but needless to say, it definitely has value. I think the tests are only going to get better. And I think the big question is, how does each person want to integrate these screening tools into their strategy? And I think people should make informed decisions. So it is good
Right.
to understand sort of like, where are you at? What do you already get in standard of care? What are the things that you're left exposed to? And when should you start doing it? And how often should you do it? Because these tests are one point in time. Um,
Right.
and so like I'm very positive on the innovation that's going on. I think we're continuing to build evidence around the research. We definitely order these tests for patients who need them and who are interested, and help them work up findings. But there's a lot of nuance, and I think most people don't necessarily appreciate the nuance.
Yeah. And no, I think in that way, doing an assessment and really creating a plan
Yes.
and being sort of smart about it, but it's not like you're alone. You're working with people, professionals, clinicians to really create a plan for yourself,
That's right.
whether down the road you are diagnosed with cancer or not.
Yes.
Um, I think the peace of mind part of that is huge,
Totally.
because knowledge is power, and it being informed. I think most of us gravitate towards having comfort with that more than just not knowing, you know.
Totally. And I'll just make maybe one point. So I've done a multi-cancer detection test because it sort of indicated if you're in your 40s and you have elevated risk, which I do, sort of it's appropriate, or if you're over 50 with no risk, it's appropriate. And it was a great experience. They did not find anything. But I also know that just because they didn't find anything, it doesn't mean there isn't anything. So it's like interesting because it was valuable information for sure, but I also know it was insufficient information because these tests are still imperfect at catching early stage cancers.
Yeah.
So it could absolutely be missed if it's a stage 1 or even a stage 2, which is why you have to repeat it. Sort of the recommendation is you do this every year. It's like an annual screening. If you didn't catch it in year 1 when you're pre-symptomatic, maybe you catch it in year 2 when you're pre-symptomatic, which is still earlier than if you are symptomatic. So it's still a net positive.
Oh, I completely agree with that. This has been really fascinating, and I think there's going to be a continued conversation about this. Definitely want to know where all of this goes. And right now, I recommend anyone who has any questions, who wants to do this assessment, to go onto Previvor Edge website. It is easy, it is quick, and incredibly helpful and informative. So thank you, Michelle, so much for being here and joining us and just sharing very fascinating information that I think speaks volumes about the future of cancer prevention. So thank you so much.
Thank you. Perfectly put.
I also want to tell people next week we are going to be talking to one of our medical advisory council members, Dr. Stephanie Blank, who is at Mount Sinai and one of the best GYN oncologists out there. Thank you so much, Michelle. I
Thank
really
you.
appreciate you making the time for us.
Awesome.